Hello, everyone. Welcome to the Green Top Guidelines Summary of the Day. Today, we are here to discuss about the management of inherited bleeding disorders in pregnancy. The Green Top Guidelines 71, published in April, year 2017. This guideline is a nightmare for students, and I always do a comparison in the live session of MRCT Part 2. This guideline is intended for both specialist hematologists and obstetricians who have experience in managing pregnant patients with bleeding disorders. It covers lots of conditions, but the most important are hemophilia and von Willebrand disease. The clinicians should be aware that hemophilia is an X-linked condition associated with reduction or absence of clotting factor, factor 8 or factor 9. Hemophilia A and hemophilia B, respectively. Up to 50% of neonatal males with severe hemophilia have no previous family history. In these cases, there is a 90% chance that a mother is a carrier, with risk to the next male child as well. So we need to know and understand the family tree in the situation. Here, I would like to emphasize that the genetics question, they always include the hemophilia in your exam. Females at risk of carrying hemophilia, particularly severe hemophilia, should be tested for the genetic mutation present in affected family members if available. Clinicians should be aware of the different phenotypes and severities of hemophilia, as this influences the risk and required management as well. Known or potential female carriers may have low factor 8 or 9 levels. The levels should be checked prior to an invasive procedure or in association with the bleeding symptoms. Clinicians should be aware that carriers of hemophilia are at increased risk of bleeding with invasive procedures, termination, and spontaneous miscarriage, and at the time of delivery. Male neonates with hemophilia are at increased risk of bleeding, including the intracranial hemorrhage and extracranial hemorrhage as well. Male neonates with hemophilia are at risk of iatrogenic bleeding following delivery. The baseline factor level should be determined prior to the onset of pregnancy. Before pregnancy, the general health of women who are carriers for hemophilia should be optimized, including attention to weight and correction of any iron deficiency. The genetic counseling should be provided to women at risk, ideally before pregnancy, by appropriately qualified and experienced clinical staff. Written informed consent should be obtained in advance of any genetic testing. The carriers of severe hemophilia should be offered pre-implantation genetic diagnosis. The carriers of severe hemophilia with a male fetus confirmed to be affected by hemophilia should be counseled to enable informed choice. All carriers of severe hemophilia should be offered fetal sex determination by free fetal DNA analysis from 9 weeks of gestation. I repeat, from 9 weeks of gestation. Pregnant carriers of severe hemophilia with a male fetus at risk of hemophilia should be offered the option of prenatal diagnosis, that is, chorionic villus sampling at 11 to 14 weeks of gestation. All carriers of hemophilia with male fetus should be offered third trimester amniocentesis if diagnostic investigations have not been previously performed to determine the hemophilia status to inform about the options of the delivery. Multidisciplinary team has to be there, including hematologists and obstetricians with expertise in this field. Maternal factor, factor 8, factor 9 should be checked at booking before any antenatal procedure in the third trimester, and these levels rise in pregnancy, but factor 9 tends to remain stable. Aim for factor 8 and 9 levels in the antenatal time period is at least 0.5 international unit per ml to cover the surgical or invasive procedures or spontaneous miscarriage. If treatment is required, factor levels of 1 international unit per ml should be aimed for and not allowed to fall below 0.5 international unit per ml until hemostasis is secure. Tranexamic acid should be considered in combination with treatment for all those with levels of less than 0.5 international unit per ml, or as sole therapy for those with levels above 0.5 international unit per ml. If clinically indicated following miscarriage, it should be continued until the bleeding settles. Desmopressin can be used antenatally to raise factor 8 levels. Due to antidiuretic effect, the fluids should be restricted to 1 liter for 24 hours after use. I repeat, 1 liter for 24 hours. If not possible, electrolytes should be monitored. Recombinant factor 8 should be used if levels obtained with desmopressin are insufficient or in a known non-responder. Recombinant factor 9 is required to cover the invasive or surgical procedures in women with factor levels less than 0.5 international unit per ml. Desmopressin can be used antenatally to raise the factor 8 levels due to antidiuretic effects. As I've discussed earlier, you have to do the fluid restriction for this patient. When giving the treatment to raise the clotting factor levels, it is important to monitor the response to the treatment by measuring the plasma clotting factor concentration before and after the infusion and 4 to 6 hours following the treatment to facilitate the dosing. A clear plan for the intrapartum care of a carrier and the baby should be available in advance of 37 weeks of gestation. The women should be seen in the anesthetic clinic, and the neonatologist should be informed of the intended delivery of a baby with hemophilia. External cephalic aversion should be avoided in affected or potentially affected male fetus and female fetus who are obligate or possible carriers of severe hemophilia B. If antenatal diagnosis has not been performed in a male fetus, then he should be managed as if he is affected. A very important exam question. The option of a planned lower segment cesarean section should be discussed for the delivery of affected male babies, especially those with severe hemophilia. If the fetal status is unknown, then this baby is taken to be a male baby. If elective cesarean section is attended, this should be at 39 completed weeks with a clear plan for the event of spontaneous labor occurring beforehand. For intended vaginal delivery, spontaneous labor is preferred. If no other obstetric concerns, to minimize the risk of intervention, measures should be taken to ensure the expertise and necessary resources are available at all times. The fetal blood sampling and the scalp electrode should be avoided in babies expected to have severe or moderate hemophilia. In babies potentially affected with mild hemophilia, judicious use of fetal blood sampling and scalp electrode can be considered in order to facilitate the vaginal delivery and avoid the morbidity associated with cesarean section in labor. This decision should be made by a senior obstetrician. Where fetal blood sampling is used, sustained pressure under direct vision should be used to ensure the hemostasis. The use of the ventouse and the mid-cavity forceps should be avoided for male babies at risk of hemophilia. The plan for the intrapartum management in the second stage of labor involving a senior obstetrician should be documented. There is no evidence to recommend the special measures for delivery in women carrying the female fetus. A female fetus who is at risk of carrying the severe hemophilia B may theoretically be more at risk of intracranial or extracranial hemorrhage, and this should be considered in the birth plan. Experienced clinicians should be involved in decisions about whether or not to perform a central neuraxial anesthetic technique, and the woman should be given all the information she needs to make an informed choice. Intramuscular injections should generally be avoided if factor 8, 9 levels are less than 0.5. They may be used when a woman's factor is maintained in the normal range by clotting factor support or the desmopressin. Remember for exam that factor 8 and factor 9 levels of more than 0.5 international unit per ml, I repeat, more than 0.5 international unit per ml are required for the insertion and removal of epidural catheter and for the spinal anesthesia. The most suitable form of analgesia depends on the context of the delivery. All carriers should have the opportunity to discuss the analgesia with the senior anesthetist prior to delivery. A clear plan for analgesia and anesthesia should be available in the maternal records. If clotting factor levels are less than 0.5, desmopressin should be given to raise the factor 8 or factor 9 concentrate should be given to raise the factor 9, aiming for 1 international unit per ml. The tranexamic acid could be considered as sole therapy for women with low normal levels and in conjunction with desmopressin to increase the factor 8 or with substantive factor 9 treatment. This should be given as close to delivery as possible. To minimize the risk of postpartum hemorrhage, it is important to recommend or for active management of third stage of labor. Tranexamic acid should be continued postpartum until the lochia is minimal. Levels of factor 8 and 9 should be maintained above 0.5 international unit per ml for at least 3 days following an uncomplicated vaginal delivery or 5 days following instrumental delivery or cesarean section. Management should be guided by results of factor assays. The pharmacological thromboprophylaxis should generally be avoided where the factor levels is 0.6 international unit per ml or less, but will need to be considered in women with thrombotic risk factors with careful balance of the risks. Following discharge from hospital, the hemophilia center should maintain contact with the women who should be advised to report any increased risk of postpartum blood loss is there. The cord blood sampling in the neonate and the diagnostic testing is recommended for male babies born to the mothers who are carriers of hemophilia A or B, although some mild cases may require retesting at 3 to 6 months of age. The cord blood sampling and diagnostic testing of female babies who are carriers of hemophilia is not recommended. Parents of neonates diagnosed with hemophilia should be informed of the diagnosis in a timely manner, and arrangements should be made for neonatal follow-up at hemophilia center. In neonates with hemophilia, information on the symptoms and signs of intracranial hemorrhage should be provided at the time of discharge. The short-term primary prophylaxis should be considered in severe and moderate hemophilia in infants considered to be at increased risk of bleeding due to trauma at delivery or prematurity. Clinical bleeding events in neonates with hemophilia should be managed in accordance with the treatment guidelines. In a neonate with low factor levels, vitamin K should be administered by an oral regimen, and following neonate blood spot screening, pressure should be sustained to avoid the excess bleeding. The cranial ultrasound should be considered prior to discharge in all neonates with severe or moderate hemophilia. Cranial magnetic resonance imaging should be undertaken in neonates with symptoms or signs suggestive of intracranial hemorrhage, even in the presence of a normal cranial ultrasound. In a neonate with low factor levels, vitamin K should be administered by an oral regimen, and following neonate blood spot screening, pressure should be sustained to avoid excess bleeding. The cranial ultrasound should be considered prior to discharge in all neonates with severe or moderate hemophilia. The cranial magnetic resonance imaging should be undertaken in neonates with symptoms or signs suggestive of intracranial hemorrhage, even in the presence of a normal cranial ultrasound. The von Willebrand disease is a second important inherited bleeding disorder in pregnancy, which comes in exam. So we have the partial quantitative type 1, the qualitative type 2, or a severe quantitative type 3. The classification is important for diagnosis, treatment, and counseling of patients. However, it does not reliably predict the response to therapy and has a variable association with von Willebrand factor gene mutations. Clinicians counseling these women should be aware that the inheritance of von Willebrand disease is autosomal and variably dominant or recessive depending on the von Willebrand disease type. Genetic counseling about the risk of the disease transmission and its variable penetrance and expression should be provided for all women with von Willebrand disease type. We should keep the factor levels above 0.5 international unit per ml as in hemophilia. So prior to the conception, the bleeding phenotype should be assessed, historical diagnosis reviewed, and response to desmopressin established. All women with von Willebrand disease should have von Willebrand factor antigen levels and activity and factor 8 levels checked at booking in the 3rd trimester and prior to any invasive procedures. Safe management requires a multidisciplinary approach. Women with type 2 and type 3 or severe type 1 von Willebrand disease should be referred for parental care. This is going to be prenatal, preconceptional discussion. Now, this discussion should also include all the antenatal care management, the high-risk obstetrics, and in the preconceptional counseling for the prenatal care, they must be referred to the expert. Clinicians should aim for factor 8, von Willebrand factor, and also they should maintain it above 0.5 international unit per ml as discussed earlier. Same as that of hemophilia, where invasive procedures are required, if von Willebrand factors, this has to be completed, checked that it's more than 0.5 international unit per ml. However, They should receive the desmopressin if they are responders. Treatment should be desmopressin in preference to the blood-derived factor concentrates wheresoever it's possible. Again, the fluid intake has to be restricted, as I have mentioned earlier. Target peak von Willebrand factor activity levels should be 1 international unit per ml and levels maintained above 0.5 international unit per ml until hemostasis is secured. For most antenatal procedures, a single preoperative treatment is sufficient, but in some cases, a second dose may be required at 12 to 24 hours, depending on the nature of the procedure and the measured levels. The timing of the treatment should be as near to the delivery as possible, and pre and post-treatment levels of von Willebrand factor activity and factor VIII levels should be measured and repeated after delivery, or if labor is prolonged in that situation. Tranexamic acid should be considered in combination with treatment for all those with von Willebrand factor activity less than 0.5 or as sole therapy for those with levels above 0.5 if clinically indicated. This can be given orally or intravenously and can be started prior to delivery. The mode of delivery should be guided by obstetric indications. Spontaneous labor and normal vaginal delivery should be permitted if there are no other obstetric concerns to minimize the risk of intervention. For fetuses at risk of having type 2 or type 3 von Willebrand disease, the fetal blood sampling, external cephalic version, fetal scalp monitoring, venous delivery, and mid-cavity forceps should be avoided in that situation. For patients with type 1 von Willebrand disease, where von Willebrand factor activity has been normalized by pregnancy or treatment, central neuraxial anesthesia can be offered in that situation. However, the factor levels must be more than 0.5 international unit per ml. Prior to the delivery, all women should be given an opportunity to discuss the analgesia with senior obstetric anesthetist. Again, for labor, it has to be more than 0.5 international unit per ml. And following delivery, for at least 3 days following the uncomplicated vaginal delivery, and for at least 5 days following the instrumental delivery or after cesarean section, these factor levels need to be maintained above 0.5 international unit per ml. Intramuscular injections, the Green Top guideline wonderfully says again that it has to be if only the factor levels are more than 0.5. The tranexamic acid can be given in this situation in the postpartum period 1 gram 3 to 4 times a day for 7 to 14 days. In some cases, prolonged administration for 2 to 3 weeks or more may be necessary. Women with von Willebrand disease should be made aware of the risk of delayed bleeding and be encouraged to report the excessive bleeding. For women with more severe cases, hemoglobin should be monitored in regular contact where the patient is maintained for several weeks in that situation. If thromboprophylaxis is indicated, low molecular weight heparin may be given in patients with adequate correction of von Willebrand factor and factor VIII as well. Cord blood samples need to be taken for babies at risk of type 2 and type 3 von Willebrand disease. And the neonates with type 3 von Willebrand disease should be considered for routine cranial imaging prior to discharge and for short-term prophylaxis with factor concentrate if there has been significant potential trauma at delivery. Factor XI deficiency. It's an uncommon autosomal disorder which has both the recessive and dominant inheritance pattern. Very rarely you can expect this question. Generally, the questions are from hemophilia and von Willebrand disease. However, the spontaneous bleeding is very rare in this situation, even with very low factor XI levels. However, these patients are often at risk of bleeding following a surgery or a trauma. So if they have excessive bleeding after miscarriage or termination, especially if they have a bleeding phenotype and if they have increased PPH, only then the treatment is advocated. Tranexamic acid should not be given simultaneously with prophylactic factor XI concentrate, as this is considered to increase the thrombotic risk. Please, an important single-based answer. For many women, it is likely that tranexamic acid alone will be sufficient to prevent the postpartum hemorrhage. Patients with factor XI deficiency should be assessed for the presence of other potentially compounding factors, such as low von Willebrand factors levels or the platelet dysfunction. As I told earlier, factor XI or tranexamic acid should not be given together Mostly, it does not require in the antenatal time period unless the invasive procedures are being undertaken, and the delivery plans for these patients are individualized. The central neuraxial anesthesia should not be given to women with low factor 11 levels, specifically if they have a bleeding phenotype. The clinician should be aware that rare bleeding disorders include the inherited deficiencies of fibrinogen factor 2, factor 5, factor 7, factor 10, factor 11, and factor 13, combined factor 5 and factor 13 deficiencies, and congenital deficiency of vitamin K dependent factors. Therefore, the genetic counseling should be provided. For affected women or asymptomatic heterozygotes carriers, consanguinity needs to be checked, and we need to understand that this patient can have the potential affected baby. Therefore, referral to the geneticist is recommended. The treatment plans, they may need to be modified according to the nature of the individual bleeds, the procedure, the background bleeding, the phenotype, and the factor replacement therapy is usually advised for delivery in women with severe coagulation factor deficiency or a bleeding history. Tranexamic acid at a dose of 15 to 20 milligram per kg or 1 gram 4 times daily alone can be used for minor bleeds and in combination with factor replacement. If the baby is at risk of severe deficiency, the delivery plan should include the avoidance of ventouse, mid-cavity forceps, fetal blood sampling, and the scalp electrode in that situation as well. The prothrombin factor 2 deficiency, less than 0.2 international unit per ml, there is significant bleeding, established labor, or prior to cesarean section, give prothrombin complex concentrates in that situation as well. For significant bleeding of factor 5 deficiency or delivery in women with factor 5 activity less than 0.2 international unit per ml, 15 to 25 ml per kg fresh frozen plasma should be considered once in established labor or before the cesarean section to achieve the factor 5 activity for the patients. Factor 7 deficiency, again, less than 0.2 international unit per ml in the third trimester with prior history of bleeding, consider recombinant factor 7A, 15 to 30 micrograms per kg every 4 to 6 hours for at least 3 or 5 days following cesarean section. For all other women, recombinant factor 7A, 15 to 30 micrograms per kg is recommended only in response to abnormal bleeding. For delivery in women with factor 10 activity in the third trimester who have a history of bleeding and all those who require cesarean section use prothrombin complex concentrate in that situation. The antenatal prophylaxis may be considered in women with a history of recurrent bleeding or adverse pregnancy outcomes using prothrombin complex concentrate 20 to 30 international unit per kg 2 or 3 times a day for a week and to maintain the factor levels 10 above 0.01 international unit per ml. A very severe factor 13 deficiency during pregnancy, increased intensity prophylaxis is required using factor 13 plasma concentrate or recombinant factor 13 in that situation. Combination of factor 5 and 13 for a delivery in women with combined factor 5 and 13 deficiency, if factor 5 activity is less than 0.2 in the third trimester, consider the fresh frozen plasma 15 to 25 ml per kg once in established labor or before cesarean section to achieve factor 5 activity in that situation. Fibrinogen disorders. Now, clinicians should be aware that it can be autosomal recessive. We call it as afibrinogenemia or autosomal dominant with quantitative or qualitative defects and are associated with variable clinical phenotype. Clinicians should be aware that severe fibrinogen deficiency may be associated with bleeding, but quantitative and qualitative deficiency can also be associated with thrombosis and the pregnancy loss. So if the functional fibrinogen is less than 0.5 gram per liter, consider prophylaxis throughout the pregnancy with fibrinogen concentrate initially 50 to 100 milligram per kg twice per week, adjusted to maintain through fibrinogen activity more than 1 gram per liter. Higher doses of fibrinogen concentrate are likely to be required to maintain the fibrinogen activity as the pregnancy progresses further. Fibrinogen replacement therapy is associated with a high risk of thrombosis and requires the vigilance as well. Moreover, the central neuraxial anesthesia, NSAIDs, and intramuscular injections should generally be avoided for women with severe fibrinogen deficiency or a personal or family history of bleeding due to difficulty in assuring the correction with factor concentrate. Clinicians should be aware that the spectrum of bleeding in patients with platelet function disorders varies and may first present in pregnancy itself. The Burnett-Solier syndrome. The clinicians should be aware that this Burnett-Solier syndrome is caused by a genetic abnormality of an important platelet adhesion receptor and is often associated with severe bleeding phenotype. It's usually autosomal recessive. It is associated with significant risk of primary and secondary postpartum hemorrhage and wound hematoma. The management of delivery therefore requires careful planning with multidisciplinary team. Tranexamic acid should be given at the onset of labor and continued regularly through the postpartum period until lochia is minimal in this situation. Clinicians should be aware that Glanzmann's thrombasthenia is a disorder of platelet function with autosomal recessive inheritance and is often associated with severe bleeding tendency. Desmopressin has not been shown to be effective in Glanzmann's thrombocythemia, and we need to remember that it's unlikely to be helpful. The central neuraxial anesthesia should be avoided. The fetal maternal alloimmunization does not occur, and there's no need to restrict aids to the delivery. Amniocentesis with platelet typing may be considered in cases of paternal heterozygosity in that situation. The neonatal care of potential alloimmunization requires a cord platelet count and withholding intramuscular vitamin K until the result is known, or administrate it orally altogether. Women with mild platelet function disorders may require treatment to cover delivery. The desmopressin, tranexamic acid, can be used to cover delivery. The Appendix 2, the stratification of maternal bleeding risk, the high risk, the medium risk, the mild risk, and unlikely to be at risk, an important table. This is the methods of prenatal diagnosis. Please have a look for MRCT Part 3 OSCE station as well. The investigations, the procedure, and what timing of the gestation, and some important information about the same. So, risk stratification of bleeding risk for the fetus and the neonate. Again, the high risk, the medium risk, the mild risk, and unlikely to be at risk. The Appendix 4 of the Green Top guideline. The neonatal bleeding risks and the management. Appendix 5 gives an outline when the fetus and when the neonate is at risk. So if you conclude this long guideline, the important exam points are the comparison between the hemophilia von Willebrand disease, both as a preconceptional care, antenatal care, interpartum care, the postpartum care, and moreover, the pedigree questions of the hemophilia in your obstetrics extended match question is pretty common. If you go to my session, you're going to see the comparison between each, and that makes it super easy to remember. Best of luck from the entire team of RFA Tutors. I thank you all for being with us today. See you next time with the next guideline. Until we meet again, take very good care of yourself. Bye-bye.